Our next area of discussion, where is breastfeeding in this large mission? Our speaker is Dr. Karin Lapping. She's a public health nutritionist and has spent the past 15 years working in international health primarily with the non-governmental organizations like Save the Children. She has an academic focus in the prevention of chronic malnutrition in countries like Asia and Africa. She holds a BA in Religious Studies from Colby College, a Master's in Public Health from Emory in Infectious Disease, and a PhD from Tufts University in Food Policy and Applied Nutrition. Dr. Lapping?
Great, thank you so much, and I appreciate everyone still kind of focused this way. I know it's been a really rich afternoon. It'll be interesting because I think we are changing topics, but not really. I think a lot of the same kind of strains that we've been hearing about how to reach communities, how to have impactful programming around the area of breastfeeding is exactly what the afternoon conversations will be about from here on out as well. So, and thank you again for inviting me. And also, I've learned a tremendous amount. I don't get to spend much of my time thinking about the domestic front, and it's really fascinating. And I think there's a lot on the international side that we can bring over, and hopefully vice versa. So I was asked to talk about where does breastfeeding fit in a broad mandate, and let me just make sure I can. Oh, there we go. Okay, so I wanted to give you a sense of a little bit about Save the Children, not too much propagandizing on that front, and then really dive into some of our programmings, both on the development side and the emergency side, and end up with some thoughts on policy and advocacy and ways forward. I'm very fortunate because Ann Peniston spoke this morning, and Ann really laid the groundwork for a lot of what I'm doing, and then I'm really fortunate as well that Jana's speaking right after me because I'm kind of sandwiched between these two wonderful donors who do a lot of support to the programming that we do and have kind of like-minded thinking. So a little bit about Save the Children. We are an international NGO, and we work across kind of the continuum of emergencies and development. So the everyday kind of motif there is really about a healthy start, which is where I fit in on the development, the kind of global health side of things. We also focus very much on education and then child protection in times of crisis and emergencies, looking at, again, preparedness for emergencies, relief efforts, and then long-term recovery and transitions back to development programming. And lastly, we also have a firm focus on policy and advocacy, knowing that we've got to kind of address those two areas and that they're not distinctly different from kind of the development and emergency spheres. We are a very large NGO. We work in over 120 countries around the world. We have a lot of different members. Despite having been at Save the Children for 15 years, we change so much in our structure all the time. It's like a new day for me, and I'm always like, I don't know. But it's a very dynamic organization. Also, interestingly, our CEO, who is not able to be here today, Carolyn Miles, is a huge proponent of breastfeeding. So it comes from the top, both there and also in London with Jasmine Whitbread. We have helped over 143 million children just last year alone, so we have a pretty broad reach. Let's see. So I wanted to dive right in, and this is going to be the 30,000 kind of mile view of some of our programming. But I wanted to give you a sense of where breastfeeding fits, again, across this broad kind of portfolio, both in the nutrition, but beyond nutrition and some of our other health programming, and also into the emergency world. So actually, again, sad that Ann is not here, but Ann was really the architect of this project that I'm going to mention. And this is a USAID. So this is your taxpayer dollars at work, and I'm happy to say I think they're being used very effectively in this situation. It's a USAID-supported project in Nepal, and it's one of the largest single kind of focused nutrition program in the world. It is across 41 districts, and you can see we've kind of expanded. So whoever mentioned kind of the whole issue of scale is very much at the basis of our theory of change. We're not doing kind of pilot programs in two communities. We are doing programs at scale or that can be scaled up, and these are scaled up through government systems. This is not Save the Children implementing aside the government. This is through the government health system. So I think it's very important in terms of sustainability. So Suhara, which means good nutrition in Nepalese, is a 5-year multi-sectoral nutrition program. If you read the USAID strategy, I think you'll see many of the elements kind of manifested in Suhara. This is the project that I probably work with the most, over 625,000 households. We do a mixture of interventions in Suhara, and again, related to Anne's presentation where she spoke a little bit about essential nutrition actions and hygiene actions. That's a real cornerstone of what we do in terms of focusing on behavior change. And a big piece of that is infant and young child feeding. And this is because early initiation of breastfeeding in Nepal is in the 40%. Exclusive breastfeeding is around 60%. Not terrible, but also not good. Severe acute malnutrition, moderate acute, and chronic malnutrition are all quite high in Nepal, unacceptably high. And then, so to complement those kind of health interventions that are delivered through the health sector, we also complement those with what we also know is driving the malnutrition situation in Nepal. Food security. So we're working on homestead food production, working on family planning, which we know is so predictive of chronic malnutrition, and also water, sanitation, and hygiene. Each of these programs, again, we go in doing basically looking at the analytics, what's actually driving the outcome we're interested in. So we're very much data-driven, designing the program based on those determinants. Therefore, you will see, while there's kind of a universe of options for what's really driving malnutrition in any given context, where you would put the emphasis will differ. And so in the Nepal situation, we're doing a lot more on water and sanitation than, for example, you might see in another country setting. I just wanted to give you a little bit more texture. So, okay, that's a whole lot of words and talking about what we, kind of the design of the project, but what does it look like and what does it feel like? So one of the things that I think, and this is, very relevant to everything we've been talking about, how to reach people and how to reach people in a way that they understand and that they can kind of interact with. So this would be super interesting on the electronic front because we're finding the same thing in international development settings. So while families may not have televisions and they may not have other electronics, they have cell phones. Usually the male has a cell phone. If the woman has access to that cell phone, might be a different story. But we're getting very involved in kind of using cell phone technology, and it's really revolutionizing the way that we're doing public health. So one of the real kind of key cornerstones of all of our work is social behavior change communications, basically the behavioral component, right? And what we've developed in Nepal, and this is a partnership with many organizations, including Johns Hopkins, who covers this part in particular, we've developed a storyline around this woman, Banchan Amma, and that means mother says. Basically, trying to tap into a whole lot of different things going on. One, that women, to try to elevate her cultural kind of importance, but also knowing people listen to mother-in-laws in South Asia. Women don't have agency over their own bodies, let alone feeding decisions. Really interesting. I lived in Nepal in 1994, and at that point, basically very kind of nuclear families lived together, and while the mother-in-law still had a tremendous amount of power, there were very intact family structures. I've been going back over the past kind of 25 years, and what I see now is massive migration. Very few men are in a lot of these communities. They're in Dubai or in Qatar. They have outsourced their labor, so the men have left. Sometimes they're accessing Facebook to talk to their wives, and these aren't impoverished communities. Technology is permeating everywhere, but who's left in the household to make decisions is the mother-in-law. So we've really focused on the mother-in-law as kind of this authority figure. And so cross-cutting all of our programmatic activities, we've used this figure, and you can see her different outfits because Suhara works across the geography of Nepal, and I'm sure you're all aware of it being an incredibly mountainous country. So you can see in the middle is actually the mountain kind of Amma, and she looks like more dressed in Tibetan kind of wear. And then we have kind of the urbanized Amma, and then we have the Amma who lives near the Terai region, the jungle region in the south. So you're going to get your culturally contextually appropriate Amma, and then we've run all of the radio programming, all of the activities, the billboards, the campaign work, the interpersonal work through the Amma storyline. And I actually just this morning was looking at a creative brief brief for the optimal breastfeeding piece, including the storyboards that we're going to be working on. We have a phone-in show, and actually the breastfeeding, exclusive breastfeeding, and complementary feeding topics were the two most popular that we've had over the last 3 years, in the thousands. I mean, shocking that people would be calling in saying, "What about eggs? What do you think about eggs?" You know, that sort of stuff. So it's really neat. It's created some sort of momentum around this issue. And then you can see a lot of the branded materials here in the corner. Most of this is delivered, the interpersonal piece is delivered through the female community health volunteer. Again, that's a government worker. We're not kind of putting workers into communities and creating something that can't exist afterwards. So just to give you a sense, and Suhara, and I'm going to come back to this project because it was very much affected by the earthquake, so I want to tell you kind of what's happening. But if you ignore the minimum dietary diversity piece, but this is basically process evaluation data, so it's not endline yet. But you can begin to see at least the trend lines are going in the direction we'd like to see. So we have some good kind of encouraging data that things are working. Now I'm going to shift focus a little bit to give you a completely different context. And this is the context of Vietnam, which is where I spent about 5 years and worked on this initiative, the Alive and Thrive initiative, which is funded by the Gates Foundation. I think Jana's going to mention a little bit more about it after me. But I'd like to hone in on Vietnam because I think it's really interesting. Vietnam is a country that, is basically middle income, urbanizing very rapidly, hugely high literacy rates for countries that a group like Save the Children would work in, high television penetration. Chronic malnutrition still, though, is at 30%, which is pretty high for its economic level of prosperity. And exclusive breastfeeding is terrible. It was our assessment was 17%, nationally 20%. So you can begin to see that this is edging towards, basically a real crisis point, but yet what usually tends to motivate people in developing countries, definitely the economic argument that was shared by the World Bank, but also the mortality argument. You're saving lives. In this situation where mortality is actually pretty low, you really do need to figure out what the message is that's going to resonate, and I'm going to talk a lot more about that. So a really kind of entrenched issue around exclusive breastfeeding, which is what we focused on. So in Vietnam, we have basically a layering effect, and this is the real, I think, message from Alive and Thrive, and it's not going to be shocking to any of you in the room, but basically the more effort you put into this at different levels, the better the outcome. And getting to the point that I think someone raised earlier this morning, we do need to figure out kind of what's the minimal level of effort to get the change we want to see, and I'll be talking about that a little bit more. But what we can do is at least discern, because we had very rigorous evaluation in this project, what basically the mass media bought us, what was attributable to the mass media campaign compared to what was attributable to the interpersonal counseling. So what's different, just, after 15 years of being in this field, we're beginning to really be able to disentangle in some of these complicated real life at scale projects, what is driving the change, and quantify that, which is really important, obviously, when you're talking about replication, affordability, governments taking this up, so on and so forth. Essentially, you can see interpersonal communication, mass media, advocacy, and then code enforcement. I'm going to talk a little bit about each of these levels. Again, all really focused on nudging that breastfeeding rate. So the national level, Alive and Thrive really focused, and this was in concert with UNICEF in particular, around some real kind of top-line efforts. One was getting paid maternity leave extended to 6 months. So it was at 4 months. We got it extended to 6 months, which was hugely, a huge uphill battle, but one that actually at the end of the day passed at 90% by the Vietnam National Assembly. And also worked on getting an advertisement law strengthened to ban the advertisement of formula for children up to 24 months. This too was quite a coup. Both of these, again, were passed at 90% of the vote. There are backstories to both of these for years. Vietnam is a really interesting place in that some of the milk companies that do the formula are actually co-owned by the government. You go into facilities, everywhere you look, there are branded materials, there are, piles of formula milk. And it's a really difficult situation because those facilities are staying alive and having furniture because of those milk companies that are also supported by the government. You can't go head to head in terms of looking at dollars invested by the milk companies compared to the public health situation. And we did a lot of analysis about how to look at this, and I'll get into that in just a moment. I don't want to steal the thunder for later in the conversation, but just to say this is not an easy one to win by any stretch, and it was really exciting to see some of these successes. A lot about what motivates folks in Vietnam was going the political route through the National Assembly. We kind of went across, the Ministry of Health does not have much power. You have to go to the Ministry of Finance, and you need to go to the political power on the National Assembly and get basically champions within those groups to really advocate. Subnationally, and again, I know this is really fast, so if you're interested in more details, I'd be happy to give them to you. Alive and Thrive has a great website about kind of the process to get to these outcomes. Subnationally, we also worked very carefully with the Women's Union, which is a mass media governmental organization, around monitoring for the code, and that has been a real issue. Obviously, policies exist on paper, but if they're not enforced, it doesn't do much good, and that's typically the situation with the code in a lot of countries. So we basically got the forces out there to monitor violations, and looked at, again, the impact of kind of violation and the training in terms of outcomes and reports. And, really promoting success stories where we could in terms of, again, this kind of monitoring piece. The mass media, and is there a way that we can click? I'm going to show you a quick clip and then I'll talk about this.
Sữa mẹ ngon quá. Nhưng mẹ cứ là không đủ sữa cho tớ. Không sao đâu. Sữa mẹ tiết ra như phép màu vậy. Khi cậu bú, cơ thể mẹ sẽ nhận tín hiệu để sản sinh thêm sữa. Cậu càng bú, sữa mẹ càng tiết ra nhiều. Hay quá. Mẹ đừng lo hết sữa cho con nhé. Mẹ chỉ cần tiếp tục cho con bú thôi. Các tổ chức y tế hàng đầu khuyên mẹ nên cho con bú hoàn toàn bằng sữa mẹ trong 6 tháng đầu. Sữa mẹ chứa đủ nước và dinh dưỡng để con khỏe mạnh và thông minh. Sữa mẹ sữa tốt nhất cho mình, toàn đầu là chứng minh.
Thank you. So what I wanted to say, so I mentioned the mass media piece, and we talked a lot about private sector and how we need to get better at marketing. So Gates Foundation helped us with this. When we said, public health people, we're not great at this, what do? They said, how about you talk to Pepsi? So we did. We got the group that Gates Foundation worked with Pepsi, and there was a person there named Derek Yak that some of you probably know at the time, and Derek basically connected us to one of the groups that, for the most part, they're out of Denver, and they sell Coors to Hispanic populations, and they couldn't have been more excited to do this for us. So it was pro bono assistance. We got them to Vietnam. They did all their formative research about the barriers, very well known, not enough, they need more water, there's not enough supply, these kind of chronic issues that you hear whether you're in Nepal or Vietnam or anywhere else, the hot climate, those sorts of things. So what they did is they got out there and began to do, consumer, kind of focus group discussions, all the things that, marketers do. And they actually started thinking that they would use celebrities promoting this and found a soccer star and, yada, yada. Anyhow, it turned out that didn't sell well with the Vietnamese population at all. So what sells well here doesn't necessarily work out well there. And what did work well are these talking babies. So the talking babies won the day, much to our surprise. We thought it would be the celebrities and the soccer players and the models and that sort of stuff. It was the talking babies. So there are a whole lot of talking baby campaigns out there. We got public service, free television from the government. And so again, you can see all those clips on Alive and Thrive, and they've done similar work in Bangladesh. one of the things that we really wanted to do is basically talk about breast milk as a product, because what we're competing against is formula. That's a product. How do you make this look like a product that's aspirational, that you want to give, that's superior? So we spent a lot of time about how to make this attractive and appealing and not something you would just throw away because you want to modernize and buy something. The other thing that I thought was really interesting is they would say, well, we like the US, we emulate the US, what do you guys do? That's a tragic story, right? Not a good thing. So that's something we've been talking with UNICEF and the breastfeeding initiative there, the advocacy, because the good success, a lot of the success stories, maybe Norway stands out, I don't know, but there aren't great developed country experiences. And a lot of the work we do in developing countries, they look usually for kind of what's the next step up in terms of kind of economic development. We want to we aspire to that. That's not a good story for us if we're looking at breastfeeding and we look to the US. Let's see. Oh, I think I'm stuck. Okay. I'm going to speed up a little bit in the interest of time, but just to say that we also then, and what you saw the reference for at the end of that clip was referring you to our franchise system. So what we also did, knowing that interpersonal communication is really important, and actually in Vietnam, as compared to Nepal, people go to facilities, and C-section rates are sky high, and that's a really big issue, just as our kind of provider opinions and promotion of breast milk substitutes. But what we did is actually infiltrate with the government as a supporter and a co-franchisor franchises, infant and young child feeding franchises. So we embedded these in the public health system from hospital levels all the way down to kind of clinics and small little, kind of one-room service facilities in commune. They're called commune level. Basically, they're at the commune level, which is like a village level. And within these, we created a franchise. We thought, again, we want to make infant and young child counseling and feeding look like something that you want, that you aspire to. You're not paying for this. It's through the government health system, and actually national insurance. We're working on getting that covered. But it's something that you feel is valuable enough that you are going to go back for a series of counseling sessions. And these counseling sessions, trying to, again, make them attractive enough and appealing enough and engaging enough that we can keep you in our system for a variety of contact points. And these contact points were around the key transitions. So we actually had 15 contact points over 27 months. We're still trying to figure out what's the lowest we could go on those contact points and see the outcomes behaviorally that we'd like to see. So these still exist. If you go to Vietnam, you see the smiling sun. That means it's a franchise that was set up and the government is now running. What we did to complement this in more rural areas where they don't access facilities is basically set up a more traditional infant and young child feeding support group. So, again, recognizing that not everyone has access to a facility or would go to a facility. There are a lot of ethnic minority groups in Vietnam that are kind of outside of the system. So we also want to supplement that. So what were some of the results from this? This was a randomized control trial. It's going to be published. IFPRI did the evaluations. One of the real benefits of working with Gates Foundation funding is that they very much support really data-driven, very intensive efforts. And so we have process evaluation mapping out the different points along the pathway to what we thought was success, so we can see if we're deviating why. And then we had very rigorous impact evaluations. And this is just coming out now for Ethiopia and Bangladesh, Vietnam and Bangladesh has come out a little while ago, and Ethiopia is coming out now. But you can basically see, again, for early initiation, no prelactal feeds were having significant impact. And again, this is through a randomized control design, so it's quite rigorous. And also exclusive breastfeeding. We had quite significant impact in the intensive areas compared to the non-intensive areas where we worked. And bottle feeding went down as well. Again, there's actually a Lancet paper coming out with those results and a whole lot of other documentation. So I just wanted to give you a little taste, not to get into the weeds of it, but I'm happy to give you more references if you're interested. Given that my topic was where does breastfeeding fit in a large global mandate, it fits very squarely in the middle of my portfolio on nutrition, but it also fits within a lot of different other kind of thematic areas, including child protection, HIV, agriculture, food security, and certainly work that we do around new newborn and child health. And one of the key areas that I think Jana might speak a little bit more about, a Gates-funded project that we work on called Saving Newborn Lives, and very much focusing on kangaroo mother care. We've heard a lot about, in actually the last session, about skin-to-skin contact. One of the things that they're promoting just as much is the feeding part of that continuum, because oftentimes what we've found is that they focus on the skin-to-skin and the feeding piece really falls to the wayside. So a real concerted effort to make sure that it doesn't. I wanted to then bring you to another area that we probably don't talk about quite as much maybe with a group like this, or outside of the development community, because they tend to be different populations. But what do we do in emergencies? And this kind of was the strain from Nepal that I wanted to kind of keep going through. But basically, emergency situations are another place that Save the Children is quite active, as are many of the groups in this room. And this is really basically, if there's poor infant and young child feeding before an emergency, you can bet it's going to get that much worse during and after an emergency. So any positive feeding practices can really be undermined by a host of situations, including insecurity, lack of privacy, trauma, displacement, artificial feeding, and I'll show you an example in just a moment, comes in immediately. Breast milk substitutes are brought into countries immediately, sometimes with the best of intentions, but controlling how those get dispersed is incredibly important. So you get also disruptions in water and sanitation that can be really dangerous to a child, compromised hygiene. So if there is artificial feeding, it's much riskier because of these issues, and more supplies are coming in where they might have not been before. Sometimes there are situations where this isn't the case, like the Syrian refugee situation. A lot of those kids were actually fed with formula beforehand. So that creates a different situation where, are you trying to get them to breastfeed or continue bottle feeding, safely? So there's a lot of different iterations, but at least in what I'm going to talk about, it's more about having pretty decent IYCF beforehand in an emergency, then kind of aggravating that situation. And then lastly, we can compromise our own kind of positive, what we want to see, because of, there is distribution of formula. If we don't have folks that know that it's not the right thing to do, they can distribute formula quite easily. Poor counseling, misconceptions about stress. We hear about this all the time, that if a mother's stressed, she can't breastfeed. Not the case necessarily. You can also work with that mother. So a lot of stressors in that situation in emergencies. Lots of tools to help with that. And one of the things that has been a real hallmark of our emergency response is something called IYCFE, which is infant and child feeding in emergencies. Toolkits exist both with us, UNICEF, so on and so forth, but really talk about kind of going through all the different manifestations and situations you could come across. To make it a little bit more real for you, obviously recently Nepal had two massive earthquakes, and this is the project that I shared a little bit earlier in the presentation. And what you can't see so well, but I still wanted to put up here, is basically a government decree, and that's the kind of blurred writing over there, that talks about what you can and can't do with breast milk substitutes in the emergency. So this just came out a week within the emergencies happening of the earthquakes, basically setting the parameters, and this was done through the kind of global organizations facilitated by UNICEF in Nepal, to basically put parameters around where formula is going and where it's not, and how it's going to be used, and if it can be donated, so on and so forth. And so really, again, infant and young child feeding, breastfeeding at the cornerstone of any emergency response. Excitingly, what we're beginning to find is that, and we're going to have some more investigation into this because it's just anecdotal, but what we expected for the response in terms of needing a really robust, basically infant and young child feeding emergency response is not needed. What we're finding is the investments made before to get good behaviors in place have been sustained. So it's really exciting because we all need success stories. We get, kind of down with a lot of the difficulties of our work to really hear that development programming worked. Prevention worked. We're not seeing severe acute malnutrition to the rates we thought, and we're not seeing the breastfeeding issues to the rate that we thought. And if women are having issues, they're able to resolve them with the help of the female community health volunteers. So I think it's a really compelling story that we're going to do our best to document as well as possible. Just to give you a sense of some of our other emergency responses, Philippines, this was in Haiti, one of our first kind of mother-baby tents, again, giving safe places for women to kind of, have some counseling and support to get back to breastfeeding. So I'll wrap it up with talking just a little bit about policy and advocacy efforts, which are a big piece of what we do as well at Save the Children. We work on a lot of publications. Hopefully some of you have seen Superfood for Babies, Stay the World's Mother we put out every year, and breastfeeding is always a key piece of the indicator to derive kind of where are the best and worst places to be a mother. We also, hopefully do peer-reviewed publications, so the gamut of publications. Alliances, we've heard a lot about the UNICEF and WHO co-led group that we're a part of, CodeNet, which is through WHO, so it can get very specific to, basically enforcement of the code, all the way to more broad kind of nutrition groups like the Sun that Anne mentioned this morning. And lastly, one of the things that I think is most interesting to really show you where breastfeeding fits in a mandate as large as Save the Children's is on the due diligence side. So when a corporate entity comes to Save the Children and says, we want to work with you, whether it's IKEA or Mott's or, any Kraft, Pepsi, whomever, the first thing we say is, do you violate the code? If you're a code violator, we won't work with you. End of story. Not a perfect system, because then they call me and I say, I don't know, I have to call IBFAN and figure this out. Beyond the usual suspects that we definitely know violate the code. But just to say, a work in progress, but that's how central breastfeeding is to Save the Children, that this is a showstopper. If you're a code violator, we're not taking your money and we're not working with you, end of story. So that to me, is really compelling as a nutritionist. That's what I want to see my organization do. So it's exciting to be here with you all and to kind of share this information and hear more about kind of, the challenges you face and opportunities. So in closing, I'd say it's very core to our mission, breastfeeding, throughout our programming and our policy and advocacy and kind of corporate responsibility in terms of how we work with others. We certainly need to sustain our efforts and escalate. It's been said over and over again, if you kind of take your eyes off it, things will not do so well, that we really need to sustain. And lastly, partnerships obviously are critical, which is, I think, why we're all here today, to kind of learn and see how we can collaborate. So, thank you.